opportunity to present at the Abu Dhabi Anesthesia Club, and I hope you all been enjoying the talks so far. Now, the topic that I have for presentation is what can you do as an anesthetist to prevent the chronicity of pain, and what's new in the field of chronic post-surgical pain. This is a topic that has been very close to my heart, given that I'm a chronic pain physician and I've also worked as an anesthetist. I always thought, what could you do to prevent these patients coming to the pain clinic? So the learning objectives will be to define chronic post-surgical pain. Is that now included as a part of the International Classification of Diseases? So we will go through the definition, then specify typical risk factors that are responsible for chronic post-surgical pain and what can you do to prevent it. And as an anesthetist, what can you do in theater when the patient is under anesthetic in order to prevent the chronic post-surgical pain. So overview of the lecture would be definition, incidence, pathophysiology, risk factors, prevention of chronic post-surgical pain, management using multimodal anesthesia, and what's the evidence base. Now, pain, the definition of pain is now different. It's been changed in July 2020. The old definition was unpleasant sensory and emotional experience associated with actual potential tissue damage. The new one is more or less saying unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This is the definition from International Association for Study for Pain that came in July 2020. So, what is the definition of chronic post-surgical pain? It's the pain that develops or increases in intensity after surgery or tissue injury. The pain that persists beyond the healing process after the triggering event, and the usual timeline is about 3 months. Pain at the surgical site or area of injury, or projected on the innervation area of the nerve. So, the example would be somebody develops pain in the groin after the hernia surgery, and it's in the direction of ilioinguinal hypogastric nerve, and it's a chronic post-surgical pain. The pain related to dermatome or head zone after the surgery, or injuries to the deep somatic or visceral tissue. So, the other things to keep in mind when you're just defining the chronic post-surgical pain, you want to rule out other causes of pain, which includes pre-existing pain conditions, infection, malignancy, risk. Majority of the chronic post-surgical pain do have characteristics of neuropathic pain, and you need to distinguish that between the organized tissue trauma in a controlled environment like surgery, or it could be an uncontrolled accidental damage in the form of trauma. So, chronic post-surgical pain is one of the most frequent complications after surgery, and I think it's one of the most rarest one to be told to the patient. I don't know how many surgeons do, whilst going through the consent process, mention this as a complication to the patient. It has a negative impact on the patient's quality of life, and I'll tell you more about that later on. And the median incidence is about 20 to 30% at 6 to 12 months. Now we know that the population is now living longer, and we have many elderly people who are undergoing hip and knee surgeries. In addition to that, there's a rise in obesity. Inflammatory diseases are also on the rise. Increased life expectancy. So people are undergoing a lot of surgeries. There's a big volume of surgery, and because of that, there's also an increased risk of chronic post-surgical pain. And the reduction of chronic post-surgical pain is now an important subject in the field of the research because of its burden on the society and on the healthcare spend. So, chronic post-surgical pain, about 312 million people worldwide undergo surgery. Every 10% increase in time spent post-op is associated with 30% increase in chronic pain after surgery at 12 months. This is the data from one of the papers that I went through. Chronic post-surgical pain affects millions of people every year, and it's a potential burden on the healthcare system. Now, is that a real problem? What does a chronic post-surgical pain do in terms of the patient's quality of life? So look at this. This is actually an old data from 2006 from Preventive. So maintaining relationships with friends and family becomes a problem. Driving becomes a problem. Sexual relationships a problem. Maintaining independent lifestyles. So majority of these patients have to be dependent. They work, working outside of home, so they basically lose their employment. They cannot attend social activities. Their physical activity becomes a problem, like walking, household chores, lifting, exercising, sleeping. So it affects the overall life of the patient. And these are basically the functional scoring that we look for when we assess somebody's chronic pain. So it has a huge impact on the patient's quality of life. Now, incidence. Now, this is a paper from Kellett 2006 and McRae 2008, and then Wild in 2011. And if you look at the incidence of chronic post-surgical pain, amputation, thoracotomy, mastectomy, have a high incidence, followed by coronary artery bypass graft, and then followed by the knee arthroplasty. And there's another recent kind of paper looking at all these surgeries and then also dividing them into the incidence of chronic post-surgical pain overall and incidence of severe chronic post-surgical pain and the pain that lasts up to 12 months. If you look at this, you have amputation, 75%, very common to have a long-term pain after the amputation. You have, followed by that, you have the mastectomy, thoracotomy, and then we have the sternotomy. So coronary artery bypass graft, pain can last up to 12 months in 27% of patients. And then we have inguinal hernia surgery, followed by a knee surgery and the hip surgery. So just to summarize the incidence of chronic post-surgical pain, I think incidence of amputation, post-mastectomy pain syndrome, post-thoracotomy pain syndrome, inguinal hernia surgery are very high. And then in terms of the knee replacements and hip replacement, the knee replacement has a higher incidence as compared to the hip replacement. And we all know if you don't control somebody's pain, then these are the consequences we're going to face. Acute severe pain, increased metabolic activity, leads to increased oxygen consumption, leading to myocardial ischemia, reduces the regional blood flow, can lead to cabal ischemia. It can also cause problems like fear, anxiety, sleeplessness, helplessness that impairs their rehabilitation and the discharge from the hospital. It also prevents somebody from taking deep breaths, called splinting of the diaphragm, leading to atelectasis and pneumonia. And also, acute pain has impaired immune response, leading to infection and sepsis. And overall, if you don't treat acute pain, then physiologically there is an increased risk of developing chronic pain. So the take-home messages are: acute pain, chronic post-surgical pain is a continuum of acute post-surgical pain, and post-operative acute pain management is vital. Now, when we talk about acute pain management, are we doing it right? And I've looked through a recent literature and also past literature on this. And what it shows that there's been a very little improvement in the management of post-surgical pain in the past decades. We have not been doing a great job managing patients' pain following surgery. 80 to 90% of patients, whilst they were in the hospital, reported moderate to extreme pain within the first 2 weeks. And not only just the inpatient surgeries, it's also day case surgeries or ambulatory surgeries. 80 to 85% of patients reported moderate to extreme pain within 24 to 48 hours. So we have got to do a much better job at managing their acute pain. And the results suggest post-operative pain continues to be undermanaged. Now, acute pain management is a teamwork. It's a teamwork of doctors, healthcare professionals, nursing staff. Also, patient needs to be involved in the acute pain management. They need to be having realistic expectations. And also, the system, the team, and the hospital management needs to support the appropriate acute pain management. So when it comes to professionals, the research says that this is a paper from 2019 from Journal Pain. There's a professionals consistently tend to underestimate pain compared with the assessment by patients. So what do you think as a professional? Your assessment of pain might be different than what patient thinks. And this is more pronounced when there is a kind of a patient in severe pain. It is likely that it contributes to the undertreatment of the pain. But that's the professional perspective. What about the patient perspective? If you ask the patients, majority of patients are afraid of side effects. They don't want side effects. They will probably try and put up with the pain, but they are worried about the side effects of the medication. So patients prefer avoiding side effects as compared to the complete pain control. Now, from hospital point of view, what they are looking for is the early discharge of patients, and they're looking for the length of stay and this enhanced recovery concept that has been brought in. You can't just focusing on the reducing length of stay. You also want to focus on the quality of care that's been provided. There's no point in patients being discharged early from the hospital with the reduction in the length of stay and then 2 days later turning back to the emergency department with the exacerbation of pain and being admitted again. So even though the length of stay for that particular episode is small, but the patient is then coming back on a different pathway and being admitted to the hospital off the beds. So we need to decide how do we balance the efficacy and the adverse effect of pain relief. It needs to be a fine balance where we're providing adequate pain relief, but at the same time, patients aren't developing any side effects. So inadequate pain management, and what are the factors responsible for that? There is an organizational problem about 62% times. Lack of time has been highlighted because of the pressure on the staffing members. Lack of motivation, about 38%. Complexity of the pain management. And now, we do know that chronic pain and patients with chronic pain undergoing surgery are usually very complex. And I think there has been a good amount of improvement that's been made in the form of transitional pain service when these patients are then followed up in the chronic pain clinic and their medications have been optimized. And difficulty in measurements of the pain is also a factor that has been highlighted. And poor knowledge about pain treatment is also a factor responsible for poor pain management. So that's basically the sort of summary that active pain management is a very important and a vital component preventing the chronic post-surgical pain. Now let's look at the pathophysiology. So if somebody gets asked for pathophysiology of the chronic post-surgical pain, the buzzwords are, or the important factors are, central sensitization, wind-up phenomenon, increased excitatory input, and decreased inhibitory input. And if I have to put all of that, this is the diagram for all of this kind of pathophysiology. After the nerve injury, there's increased sodium channel expression. This leads to peripheral sensitization. At the same time, there's increased glutamate release from the nerve endings, which increases the nerve firing, and basically this leads to intracellular changes, sustained central sensitization with increased spontaneous impulse, leading to allodynia, hyperalgesia, and basically developing the central sensitization. So now what's the prevalence of acute neuropathic pain? Because the pathophysiology, as mentioned, 24/7 pain, majority of the patients will have neuropathic pain development in the acute phase. So approximately 10% of the patients develop acute neuropathic pain, and this is from the Pain Detect questionnaire. And this is basically the study that found the relationship between the severity of post-operative pain and occurrence of acute neuropathic pain in post-operative period. So look for neuropathic symptoms. If the patient complains of wound hyperalgesia or allodynia or shooting pain, sharp pain, burning pain, then it tells you that they have possibly developed acute. So another study showed 4.2% of mixed general and orthopedic population. They've done the Lance scoring, Lance needs assessment of neuropathic symptoms and signs. This is a very good questionnaire. They've done it after 1 day of the surgery and realized that patients can develop acute post-surgical pain. It's very important to look for these symptoms of neuropathic pain in the post-operative period. Now, this is a very good diagram telling you about the factors that are responsible for development of chronic post-surgical pain. Here, these are the general patient factors, and out of these factors, if somebody is very young, if they are of female sex, and if they have a higher BMI, these are the 3 important factors that are responsible for the development of chronic post-surgical pain. In addition to this, then the other factors that are responsible for preoperative opioid use, then what type of anesthetic technique you're using, whether you're giving general anesthetic or regional, and we will talk about that more in detail later on. Also surgery, if it's a minimally invasive surgery, there's less tissue damage, there's less trauma related to the surgery, they're less likely to develop chronic post-surgical pain as compared to someone who's undergoing a longer duration surgery, an open surgery, surgery that involves a lot of tissue damage. They're more likely to, or patients who undergo repeat surgery because of infection, they are more likely to develop chronic post-surgical pain. So let's move on to the table. This is the table that shows you preoperative factors, intraoperative factors, and postoperative factors. And I told you preoperative anxiety, younger age, female, work-related stress, genetic predisposition are responsible factors. And we've been focusing on these two areas as this could be our role, that we could do something during this intraoperative and postoperative period to minimize the intensity of acute pain, which indirectly will hopefully prevent the chronification of the pain. So preoperative factors, the severity of the preoperative pain, history of repeated surgery, opiate exposure. This is the single most important factor. Patients who have been taking opiates for a long period of time are more likely to develop chronic post-surgical pain. And also gene polymorphism, that's been considered, like the genetics also contribute to development of chronic post-surgical pain. The other factors are psychological factors, cognitive functions like visual memories, has been linked with management of like development of chronic post-surgical pain. Poor sleep is also responsible as one of the risk factors for development of chronic post-surgical pain. Intraoperative factors are type of the surgery, anesthetic technique, local anesthetic blockade, open surgery or laparoscopic surgery, and how much nerve damage has taken place. Post-op factors, what's their pain control post-operatively? Have they got neuropathic pain symptoms? Have they undergone chemotherapy or radiotherapy? And this also actually causes nerve damage and potentially can lead to chronic post-surgical pain. So now, can we predict the chronic post-surgical pain? And there's been kind of a lot of scoring systems that have been developed. One of the common ones is the Kaufman scoring system, where you have this point-based system, includes sex, age, pain before surgery, use of opioids, use of anxiolytics, open surgery or type of the surgery, obesity, and levels of anxiety. If you plug in the point system, if somebody develops a score more than 4, then they're more likely to develop chronic post-surgical pain. Similar to that, they've developed another 2 questionnaires, and this is basically giving you more details. One was developed for the breast cancer surgery, and they had 4 items: pre-op pain, BMI, whether they've had an axillary lymph node dissection, and whether they've had any acute post-operative severe pain. And the other one is developed for other surgical procedures like inguinal hernia repair, hysterectomy, or thoracotomy, and then these are the factors you plug in. So this scoring system has sensitivity of about 58% and specificity about 68%, but they do lack good accuracy because of number of studies that are involved to create these questionnaires and the sample size. Now, how do we manage chronic post-surgical pain? So we'll talk about pharmacological management, interventional management in the form of regional anesthesia, other physical modalities like TENS machine, cryocuff, acupuncture. Psychological interventions can also help reduce the development of chronic post-surgical pain and patient information and education. So when we talk about the pharmacology, this is what we basically talking: noxious stimulus, so drugs that will reduce the nociceptive pain like anti-inflammatories, nerve blocks, which will reduce the noxious stimulus, and also the transduction and transmission, followed by going up the pain pathways, so ascending input and descending modulation. So we want to kind of use the drugs like alpha-2 ligands. We'll talk about clonidine, alpha-2 agonists, acetaminophen, like paracetamol, anti-inflammatory drugs, toxins. They're basically working on the descending modulation, and the opiates work on the ascending input, and overall reducing the neuronal inflammation, which can lead to peripheral as well as central sensitization. So it's a multidisciplinary approach. Basically, you are going to work as a team. It needs to be formed with physiotherapists, pharmacists, nurses. We as a physicians play a very important role, acute pain team, and so it's a team game. Now, I would strongly urge you to look at this great publication from Faculty of Pain Medicine, Visitors, a really good resource. Another good resource is a prospect website from European Society of Physician Anesthesia and Pain Therapy. They've got some guidelines on specific procedure-specific pain management, post-operative pain management. When we talk about the acute pain management, there's a concept of preemptive and preventative anesthesia. So preemptive anesthesia is before the incision, and preventative is targeting the preoperative, intraoperative, post-operative noxious stimulus. Post-operative pain or analgesic consumption is reduced beyond the duration of action of the drug. So if you do a nerve block, then they're more likely or less likely consume more morphine post-operative. So that is one of the preventative strategies. So aim of the preventative analgesia is to reduce nociceptor activation. So as I say, like local anesthetic, decrease receptor activation for using drugs like anti-inflammatories. I'm sorry, and paracetamol, or inhibit the activity of pain neurotransmitters like gabapentinoids, clonidine, or ketamine. Now let's talk about nitrous oxide, and I'm a big fan of nitrous oxide. And I've read through this study. This was a massive study that was conducted. And it was a multi-center trial. The name of the study was Enigma trial. This was conducted back in 2010 and was conducted by Paul Miles and the colleagues in Australia. And one of the findings of the studies was, reduce chronic post-surgical pain development after use of nitrous oxide. And this was a conclusion. Chronic post-surgical pain was common after major surgery in Enigma trial. Intraoperative nitrous oxide administration was associated with reduced risk of chronic post-surgical pain. So, if you are using nitrous oxide, if you think it's appropriate or there are no risk factors of using nitrous oxide in a patient, then I would urge you to consider its use. Now, paracetamol is a very good analgesic, minimal side effects. It can reduce the morphine consumption in patients on patient-controlled anesthesia, but it does not result in reduction in morphine-related adverse events, and hepatotoxicity is very rare. Now, what do we do practically with regards to paracetamol? Use the IV paracetamol, if possible, pre-op, intra-op, and post-op, till the patient resumes his oral intake. Hepatotoxicity, as I say, with paracetamol is overestimated. What about anti-inflammatories? Combined use incidence of gastroduodenal ulcer is high, and this is particularly a concern in the elderly population. So always keep that in mind. But if there are no contraindications, patient doesn't have a history of gastric ulcers, they're fitting well, you can use anti-inflammatories. The cardiovascular risk has also been overestimated. The risk is very low with naproxen, but with the ibuprofen, the risk goes up. And there's been a paper that's been looking into the cardiovascular safety of COX-2 inhibitors like paracoxib and valdecoxib. And what the paper showed, this was basically a pooled analysis of the data from 32 studies, 17 including paracoxib and 15 including valdecoxib. And what they showed, the incidence of cardiovascular thromboembolic events are very, very low. It's 0.4%, paracoxib versus valdecoxib group. So it is low, and a lot of people are concerned about the platelet aggregation as well. And this study kind of showed paracoxib has no effect on platelet aggregation in healthy individuals. So if there are no contraindications, I would urge you to use anti-inflammatory drug in the form of oral or IV. So they have used paracoxib in orthopedic surgery, gynecological surgery, and also hip replacement. So knee replacement reduced the morphine consumption by 28%, hip replacement 39% reduction in morphine consumption, and the gynae surgery, abdominal hysterectomy, there was 36% reduction. But there was significant reduction in the morphine consumption. And as we know, if the patient continues to take morphine for a prolonged period of time, post-operatively, they are more likely to develop chronic pain. So reducing the opioid use is one of the aims for reducing the chronicity of pain. So looking at this particular study as well, if you use anti-inflammatories like paracoxib on its own, then it will reduce the consumption of morphine by 27%. If you use it with paracetamol, then it's a double whammy effect. There'll be a significant reduction in the morphine consumption. So use it as a part of the multimodal therapy rather than using it as So, anti-inflammatory drugs reduce pre-spinal, also peripheral and spinal cyclophosphamide enzymes. There's no strong evidence at present whether it prevents the chronicity of chronic post-surgical pain. And it's a side effect profile that limits use. But if the patients are fit and young and healthy and they're undergoing surgery, then can use IV or oral. Opioids. Now we all know opiates being a cornerstone for the acute post-operative pain, and we know they've been working on these kappa delta receptors. We may be able to reduce the opioids, but we cannot manage pain properly without them. And the reason I say that because they do play a role in acute post-operative pain management. And there have been talks about using opiate-free anesthesia, which is possible. But having said that, we will have to implement many things, and the analgesic severity may not be as similar to as when you use opiates. But there are concerns. We know the opiate medication sales have increased fourfold in the United States. The US consumes about 80% of the global opiate supply. So it's a big dose of an increasing number of deaths because of opiates. So what is good about opiates? They are very effective analgesics. They are effective in providing pain from major surgery or trauma. Bad thing is it causes a lot of side effects: nausea, vomiting, constipation, sedation, agitation, respiratory depression, and these are the concerns. Opiate-induced hyperalgesia is a big concern if patients are given high doses of intraoperative opiates like fentanyl. Opiate-related adverse events increases with the length of stay as well as the hospital cost, and these are the two other concerns that are being expressed: the cancer recurrence and the immunosuppression. So that brings on to what can we do to reduce the opiate consumption, the use of adjuvant drugs. So gabapentinoids is one of them, and these are the two studies I looked at which use gabapentinoids. And what the studies show, preoperative use of gabapentinoid was able to reduce post-op pain, total morphine consumption, and morphine-related complications following the spine surgery. Further studies should determine the optimal dose and whether pregabalin is superior to gabapentin. And this is actually an old study, and I've looked at a few more new studies, and unfortunately there's no conclusive. Well, actually there is one study that refuted the use of gabapentin in development of chronic pain. So this is a study on the gabapentin, 12 randomized controlled trial studies. Meta-analysis reported that gabapentin then reduced pain intensity as well as reduction in the opiate consumption in immediate post-operative period. Having said that, it did not reduce chronicity of pain. Pregabalin has a better bioavailability, better CNS penetration, and perioperative period. It's used in perioperative period showed a reduction in the opiate consumption and reduction in the persistent neuropathic pain at 3 months and 6 months. So pregabalin has some role. Gabapentin, unfortunately, didn't reduce the chronicity of pain. Now, how do we use these drugs in practice? We as a chronic pain physician use them very often if patient has neuropathic pain symptoms. So you use pregabalin as a pre-medication, give 1.5 to 2 hours before, use 75 milligrams per ml, 150 milligrams as a regular dose. And if patients fit and young, then you can actually go up to 300 milligrams per day. And this is the data from total replacement of lumbar spine surgery. Just wanted to make up a point that these drugs are only used for 5 to 7 day period. After that, they need to be stopped because they have a high addictive potential, and you don't want patients to be hooked on these drugs. So just be very mindful of the fact that these are only for short-term use. Now, dexamethasone is another drug that's being talked about in trials in order to minimize the use of opiates. So it decreases the presynaptic release of neurotransmitter and causes production of kynurenic acid, which is an NMDA receptor antagonist. So it works like very much similar to what a ketamine would do. It can reduce the opiate consumption, but the problem is it can give rise to increased blood sugar levels at 24-hour period. So there are 24 randomized controlled trials, and meta-analysis of these trials say intravenous dexamethasone is an effective adjuvant. Doses from greater than 0.1 milligram per kilogram is effective, but it will reduce possible the morphine consumption, but there's no data supporting its use for reduction in the chronicity of pain. Ketamine is another well-studied drug, and there are many studies that do say that it may possibly reduce the chronification of the pain at 3, 6, and 12 months, but unfortunately we still lack data from the bigger studies. So, it's still, the jury's still out there about ketamine. There is an emerging evidence, but we still need to wait to find the appropriate answer, whether it actually reduces the chronicity of pain. So in practice, you would use this as 0.1 milligram per kilogram per hour. Average 70 kg patient will get 7 milligrams per hour. Psychomimetic effects are very rare at this dose, but you can add some midazolam to prevent side effects, and it's useful in acute neuropathic pain and also patients with opiate tolerance. So ketamine is a drug that you can use. Alpha-2 is like clonidine, and I'm just going to whiz through this quickly. There are side effects of using clonidine. It can give rise to bradycardia, hypertension, but it can reduce opiate consumption, pain intensity, and nausea. So opiate withdrawals suppressed by alpha-2 agonists like clonidine. It has an opiate-sparing analgesic and antihypertensive effect. Potential of local anesthetic sensory blocks. So you can mix this with local anesthetic with performance nerve block. So it's difficult to conclude that clonidine can reduce the development of persistent post-operative pain to date, and the number of patients in these studies are very small, and the studies were very small. So we cannot actually predict. We cannot recommend its use. Lignocaine infusion, and there's been a lot of studies and a lot of talks about lignocaine infusion and the use in spine surgery and major colorectal surgery, and use it in enhanced recovery after surgery. So this spine surgery, they use 2 milligrams per kilogram per hour from the induction to 8 hours after the operation, and they found that there was significant reduction in the pain scores and opiate consumption at 48 hours. Unfortunately, none of them have shown any reduction in the incidence of chronic post-surgical pain in the long run. So it may reduce, but unfortunately, we don't have a strong data to support its use. And there have been cases of local anesthetic toxicity. So the Royal College of Anesthetists and Association of Anesthetists, Great Britain and Ireland, came out with a document saying that do not use lignocaine infusion unless you cannot find any other alternatives. So now, putting all this in one table, so we have basically ketamine. There are a few studies which show level 1 evidence, but prevention of chronic post-surgical pain is level 2. Pregabalin, same thing. It's inconsistent evidence in terms of intensity, but it may reduce the chronic post-surgical pain. Gabapentin, you can see here, may possibly do. Clonidine, there's no data. Lignocaine, possibly. So, and I'll actually put all of this in summary. This is what you could do if somebody is coming from moderate intensity pain. Then you can do multimodal anesthesia in the form of paracetamol, anti-inflammatories, possible original anesthetic technique, and weak opiates. Now, regional anesthesia, does that reduce the chronicity of pain? There have been lots and lots of studies that are looking into this, and there have been studies on paravertebral block reducing the post breast surgery pain syndrome incidence. Also, use of paravertebral blocks for thoracic surgery and reduce pain and reduce chronicity after post thoracotomy. So there is some evidence that suggests that it may be helpful. So let's look through this. Regional anesthesia has low morbidity if it's used properly. It has no effects on mortality or length of stay. I'm going to say in general, you don't have enough data to support its use for reduction of chronic pain, apart from breast surgery and thoracic surgery. the beneficial effect is lost when very high or repeated dose of opiates are administered in the patient. So it may reduce the need for the opiates, but if patients are already on the opiates, they then needed more opiates or repeated opiates, than the beneficial effect of which anesthesia is negated. So epidural, what's the evidence? The meta-analysis shown it reduces chronic post-surgical pain if used intraoperatively, post-operatively, in thoracotomy, breast surgery, and abdominal surgery. Now, here, these are the surgeries where they're bringing enhanced recovery after surgery programs, and unfortunately, the epidurals are basically phasing out because they want patients to be going out of the hospital on day 2. So they're not putting the epidurals, instead they are doing either a paravertebral block or a spinal plane block. It's a trend that's being followed in enhanced recovery world. Peripheral nerve blocks, regional anesthesia for breast surgery, knee surgery, hip surgery can reduce the incidence of persistent post-operative pain at 1 year. I'm not telling you about this, but it's unable to reduce chronic use of opiates after such surgery. So evidence is a bit contradicting. Wood infiltration catheters, whether they reduce the chronicity of pain is still debatable. And remember, when you're using regional anesthesia as a technique, you have to keep this concept in mind, which is the rebound pain after the regional anesthesia. It may lead to increased use of opiate analgesics and decreased patient satisfaction. So if you're performing the regional anesthesia, do mention to the patient that at one point the regional technique will not be able to manage the pain, so they will need to take some more analgesics. So what are the non-pharmacological interventions? So art therapy, educating the patient, telling them, they're undergoing surgery, what kind of pain they should expect. Physical activity like physiotherapy, manual therapy, and the dietary sort of supplementation would play. Virtual reality is coming up, and that's something that is going to have a scope in terms of reducing the chronicity, not chronicity, in terms of reducing the active post-surgical pain. So moving on to next, as I said, virtual reality, watch out for space for this. This is something that may be a game changer in terms of reducing patients' opiate requirements post-operatively, and also may reduce the chronicity of pain. So other important factor when we're working with the surgeons is they doing the surgeries with minimal invasive approaches, causing minimal tissue damage, minimal inflammation, preserving the nerves, and that can reduce the chronic development of chronic post-surgical pain. Now, so this was the old picture: boy goes to fire and then feels the pain. This was the concept that was described by René Descartes. But we know pain is not as simple as just an electric wire. It has so many components, and these are all the components that you have to keep in mind when you're managing somebody's acute pain. So including the beliefs, previous experience, descending neuromodulation, neuroimmune response, central sensitization, peripheral sensitization, nociception, stress biology. All of these factors play an important role in the management of acute as well as chronic post-surgical pain. So it's like a jigsaw puzzle, and we have many pieces, and we want to put everything together, including pharmacotherapy, physical therapy, additional techniques, rehabilitation program, complementary therapies, all may play an important role in the management of chronic in the management of acute post-operative pain, and then reducing the chronicity of pain or chronic post-surgical pain. So this was a very important statement that was made by Henry Kellett back in 2013. The important goal of any pain relieving therapy is its ability to improve perioperative outcomes in ambulation rather than to achieve specific pain scores. So don't look at the pain score, look at the other areas, which includes is a patient able to sleep better, is a patient able to mobilize better. So I'm going to summarize this. So chronic pain after surgery is common. Chronic post-surgical pain is multifactorial. There are many factors responsible for the chronicity of pain. Multiple risk factors needs to be recognized and treated early. Managing active post-op pain is an important step to prevent chronic post-surgical pain. It remains very unclear that which combination you can use, but you can start with giving them paracetamol that reduces the opiate requirements. Nitrous oxide has a preventative role. Pregabalin, as compared to gabapentin, I think pregabalin, there are some studies supporting its use. Low-dose ketamine has been sort of used in major surgeries like major spine surgeries, major laparotomies. Lignocaine infusions, as I said, there have been concerns about lignocaine infusion. These are the websites that you can look through: postofpain.org and Faculty of Pain Medicine. Australia and New Zealand website. It's got very good resources. Minimize the use of opioids, which you can do by using regional techniques if you're competent in them, and use procedure-specific evidence-based guidelines. So chronic post-surgical pain is an important clinical and socioeconomic challenge. Reducing the intensity of acute pain by adopting multimodal strategies and regional techniques can reduce the pre and perioperative opioid use, which in turn will reduce the chronicity of pain. Multidisciplinary approach is important. Unfortunately, we still are waiting for a solid evidence. The evidence for most pharmacological and non-pharmacological intervention is limited. So these are the good papers to look at. This is from British Journal of Anesthesia Education, recent article, and then another article on the persistent post-surgical pain, pathophysiology, and preventative pharmacological consideration. So this is a very good review article, so please look through that, and I hope I've given you some take-home messages. Thanks very much, and I'm sorry that I'm not able to join you live, so that's the reason I've shared the recording with Dr. Lowe, but you can reach out to me on sadiq.bhayani@icloud.com, and thanks very much, and enjoy the rest of the evening. Thank you.